Welcome to the body imaging cases. This is a case of an elderly lady with respiratory failure on mechanical ventilation. She had severe abdominal distension. The chest X-ray shows the opacities there to be distributed along the bronchovascular bundles. With close look at the opacities, we notice that there is bronchiectasis. There is a tracheostomy tube. The abdominal radiograph shows gaseous distension of the whole gastrointestinal tract, the stomach, the small intestine, the large intestine, and the rectum. This is the CT of the thorax. We start to see the bronchiectasis bilaterally, surrounded by inflammatory reaction. Candida has been harvested from these infected dilated bronchi. Right pleural effusion, and marked distension of the stomach, although it harbors a nasogastric tube. This is the abdominal CT done in search for a cause for the abdominal distension. The whole gastrointestinal tract is dilated. Stomach, small intestine, and large intestine, with no evidence of mechanical intestinal obstruction. So in this case, CT has told us a lot about what is going on in the thorax, the bronchiectasis and the infection of the bronchiectasis. But the abdominal CT didn't tell us much about what is the cause of the abdominal distension. It is clear it is not mechanical intestinal obstruction. As we see even from the plain X-ray, the rectum is very well distended with air, and on CT it has been collapsed. The reason for the abdominal distension lies in fact at the uppermost part of the thorax. If we look at the tracheostomy cuff, in this case, we find that it is over-inflated. And going back to the uppermost sections of the CT of the thorax, we see a fistula delineated by gas connecting the esophagus and the trachea. This tracheo-esophageal fistula has been created by the over-distended tracheostomy cuff, which has caused atrophy of the posterior wall of the trachea and the anterior wall of the esophagus, pressure atrophy, and a fistula has been created. So what happens is that during the mechanical ventilation, some of the air escapes through this fistula and goes to the esophagus. It is swallowed and it goes to the gastrointestinal tract, causing its distension. This is a 3D representation of the air-containing structures at the thorax, the cuff of the tracheostomy tube, the trachea, the bronchi, and the esophagus. As we rotate the frame, we see the fistula between the trachea and the esophagus. That's the fistula delineated by gas. Our learning point is that during mechanical ventilation, gaseous distension of the gastrointestinal tract may occur due to tracheo-esophageal fistula caused by the pressure of the over-distended tracheostomy cuff on the esophageal wall. The next case is a case of a male 33 years old with left scrotal swelling.